This is Digital Pathology Today. Now, here's your host, Dr. Joseph Anderson.
Welcome to Digital Pathology Today. I'm Joe Anderson. Tom Barr is a true industry veteran in digital pathology. We're going to be talking today about what it was like in those very early days of whole slide imaging and implementing digital pathology. What were some of the barriers we had to overcome? Tom was instrumental in developing the virtual imaging for pathology education and research software tool, otherwise known as Viper, at Nationwide Children's Hospital. He was also instrumental in implementing digital pathology programs for clinical trials with some of the major cooperative groups, and was also involved in the digital pathology system for the Cancer Genome Atlas program. He is currently the founder of HyperPath Solutions, and we're going to see what he can share about that venture with us as well.
This episode of Digital Pathology Today has been brought to you in part by JAV Advisors. With over 16 years' experience, JAV Advisors focuses on business and management consulting for digital pathology and artificial intelligence in deployment within histology, pathology, and cytology laboratories throughout the world. Call 213-258-6268 for more information. JAV Advisors.
Tom Barr, welcome to the podcast.
Thanks for having me, Joe. I really appreciate spending some time with you.
You're an industry veteran and have really been involved at the early stages in digital pathology and whole slide imaging and kind of an early pioneer. So maybe just tell us a little bit about your experience in digital pathology, whole slide imaging, and informatics.
I guess it was back in 2003, we really started evaluating the technology at Nationwide Children's Hospital, which was then known as the Columbus Children's Hospital. We were working with Dr. Qualman. He was a rhabdomyosarcoma guru. He just talked to me one day and said, "Have you seen this technology?" And my background was really in medical technology, working in the lab. How can we take technology that's available and make us more efficient? And really, the whole slide imaging was something that was certainly interesting to me, even at the time, seeing just the technology and really the high quality of images, even at that time. I mean, there was a lot more work to get a good quality image back then than it is now. So that was really our initial push. And we ended up selecting Aperio, which was a good move in hindsight, and really was able to partner with them very early on. We were one of their first clients, and then we were able to really take that technology over many years and make it work, really with the idea initially of providing that as a clinical trials platform to where our pathologists could get that information very quickly and make a decision on whether a patient should or should not go on an oncology clinical trial.
Making it work, that's kind of a key piece of the puzzle that many people might leave out, right? So let's just bring it way back just to the idea of whole slide imaging. I think people understand roughly what that is, that you're able to scan a whole slide at various levels of magnification and view it on your display or monitor. You went with the Aperio scanner. Aperio is one of the early manufacturers of scanners. We've had this capability for roughly 20 years or so, but let's just talk about what's involved in whole slide imaging. Because I think once we got the scanners, there's much more to it and to actually make it work, as you said.
I think initially it was really the hardware and just getting a quality slide and giving our pathologists, our researchers, an image that would mimic what they see on the microscope. And that was really challenging early on. You really had to babysit these scanners to get them to provide a quality image. And then as you start doing more of the 40x scanning, it further complicated that whole process. And then once you were able to get a good image, what do you do with it? How do you share it? Where do you store it? And how do you share it quickly? Because I think, especially back then, bandwidth limitations, and we still have that today. But at the time, we were sharing this data out with pathologists all over the country. And we used to always say, we had a very good relationship, developed a really good relationship with the Ohio Supercomputer Center at the time. And that was a huge advantage to us because as we were having conversations with our people at Children's, hey, these images are about a gigabyte each, right? Well, that was very scary. back then, because a gigabyte of data meant something different really to us when we hear it than when we hear it today. So, being able to generate quality images was a challenge, and then being able to store that data and back it up was certainly a challenge, especially with those data sets at the time, the size in the healthcare system. They're much bigger than radiology images, and so when you're talking to the IT people, they would get really nervous at that time about that much data being produced. And for us, for example, I remember one of the key things was anytime whatever we do digitally, it has to be the exact same as if we were doing this the old way. So I think initially the hardware was an issue, and then as things have moved along, there was a lot of focus on hardware, and we've certainly seen the benefits of that. And then the problem really at that point became software, and having the ability to share this and share it with the right people, and make sure it's secure, and things of that nature. That was really things that people began to focus on, companies, vendors began to focus on more later, but the initial push really was just being able to generate a good image.
Certainly, Moore's Law comes into play, right? The cost of storage and our ability to store these large files so cost is going down, hopefully exponentially towards zero. Our ability to store the files is going up. So hopefully we're the beneficiary of that. And then, like you said, other hardware solutions are coming online. And so now we're kind of entering the era of software, where we can have companies develop platforms to kind of sit on top of the existing hardware. So how far have we come since the early 2000s?
We've came a long way, and like you said, Moore's law is certainly part of that, because the cost for storage and has really it's went down significantly. I mean, if you go to Best Buy or somewhere, and you could, I think I bought my kid a 4 terabyte drive for $60, and if you'd have told me 20 years ago you can get 4 terabytes for $60, eventually I would have said no way. So we have seen that, we've seen the impact of that, and I think there's a lot of benefits with some of these new software tools, and really just being able to interoperate the different robots and make those work together. I think there's certainly some real advantages there. I believe just with some of the hardware companies really focusing on hardware, it really opened up opportunities for some of these what I would consider really middleware software applications, to where they can not only serve that information out quickly, but really be able to to collect a lot of information with that to enrich that data set. And that was a missing piece for many years. But I think progress has certainly been made. It's exciting to see where it's at today. We've joked in the past that if you'd go to a conference 15 years ago, there would be a few people, you and maybe another person or two, in the back corner that's talking about whole slide imaging or digital pathology. And that's really shifted now to where we have conferences, and have had conferences for many years that's focused just on this one field. It's pretty cool to see happen firsthand.
We're kind of in the midst of the perfect storm. I think we've seen vast improvements in technology, and then this global health emergency kind of gave us an extra shot in the arm to really, now we have a focus on digital pathology and working strictly digitally and even remotely. So I think we're in very exciting times. Let's talk about networking and interoperability. You identified the need at your hospital, and so it's one thing to be able to scan the slides and have the pathologist review cases in a single institution, but what about when you want to start sharing cases nationwide or even within a department? There comes the need for networks and then all of the components to work together. So how did you go about that, going from just one pathologist looking at cases at Nationwide Children's Hospital to developing a network, and then even developing tools to link institutions together and so forth?
And that was a big challenge for us, and I think a challenge for a lot of people, being able to do all that in one place. It's not easy, but when you start expanding that out, and having the need to for pathologists at different facilities, or for us, a lot of our pathologists would even they would review cases in the evening at their house. And early on, the easy way for us to get around that was we would use the hardware, generate the images, put them on an external hard drive, and send them out. And obviously, that was a step forward, but still, our goal was really to be able to share the stuff quickly so that initially patients could get put on the right clinical trial much faster than what we had done the old way. So the hard drives was a band-aid at best. And then we really looked at working with as high a provider as we could find to serve images out from our facility, as much bandwidth as we could possibly have, getting that out, understanding that you're still going to have a pathologist that's on on his Wi-Fi at his house, right? So that still presented a lot of issues. I think a lot of the compression schemas, for example, going from JPEG to JPEG 2000 several years ago now, that was a huge help with that, because you were still getting a very high quality image, but it was smaller, about 25% smaller, which meant that these pathologists or researchers could get this data quicker. But we still had limitations even with that, and I think we had, I can remember one researcher, or one pathologist in Kentucky, and we were having all these problems. We were jumping through all these hoops. We were doing whatever we could to look at what else is going on with the server, looking at the logs, what else, or something wrong on our end, only to find out that he was sitting in his lazy boy reviewing cases over his home Wi-Fi, and it really led us to the we can only do so much. I mean, certainly we can optimize our network. We can use a really big pipe to push data out. But if they're reviewing cases and it's got to go through a straw, we always use the analogy. We felt like we were pouring the data out from a 55-gallon drum, but if it has to go through a straw to get to your house, if you're reviewing there, then there's issues there that we really just can't. It's difficult for us to fix for you. But being able to make the better compressions was huge. Bandwidth going out was huge, and even hardware on computers, on their laptops or on their reviewing stations. As that improved, it helped as well. We even looked at prefetching, some things that we had done in digital or in radiology 20 years ago. If we know what images are going to be needed next, putting those on faster disk storage. So we did some things like that to try to help that process, and I think a combination of those things helped it improved. But there were still limitations, and there's still limitations today.
I think there's a lot of applications in digital pathology. I think that's an understatement. Many, many applications in different workflows. We're doing different things. And it sounds like you were focused largely on clinical trials, which I think is going to be a huge opportunity for digital pathology, really to enhance the results of the trials for the benefit of patients, but also to increase the participation or extract as much information from the histological images in these trials. So you talked about working with some of the cooperative groups such as the GOG or the COG, and there's many out there. It's like an alphabet soup. So we have SWOG, the NSABP, and so on. So I think that this is a huge opportunity. So maybe tell us a little bit about your early work with these cooperative groups and kind of what the needs of the groups were and where things are going.
Certainly, there's a huge opportunity there. In the beginning, developing software, we developed a LIMS system and a document management system and some other things really specifically for the biorepository. We were initially begging pathologists to use the technology and trying to show them, here's an opportunity to help get these patients on the clinical trial, the right clinical trial. We were competing with slamming glass. These pathologists are really good at slamming glass. They're really quick at doing their work that way. How do we make the technology better? What can we do? But in addition to that, really presenting this back to the pathology communities that we were working with is, there's other opportunities here. There's things that you can gain and data that's available when that becomes a digital image that's not available to you on a glass slide. So we really preach another tool in the tool belt. And I think we're really starting to see that now. And there was quite a bit of pushback. I mean, we had pathologists that just flat out refused to use it at the time. And then we had other pathologists that, found it intriguing and was willing to try it. And I think what we found, as it's like anything else, as it becomes if you start hearing good things about it from your colleagues, then you're more likely to jump in and try it. And really, that was the approach we took initially is, hey, this technology is available, and we'll provide training. We'll do whatever we can do to make this technology available to you. Once you start getting a few people on board, and we have more pathologists that were willing to try it. And really, our approach was the more people we can get involved, the better. We really looked at the pathologist perspective and made sure that anything we did in the software was really done in an effort to make that platform better for them. And I think they recognized that as well. And we were able to really to build that up as we went. And, at one time, I think we had over 150 pathologists that were using the system. So, we went from one or two we were bagging to over 100. And really, that I think that comes down to improvements in the technology, but also just being able to build a system that is going to work better for them and really making them part of the solution.
So it sounds like you're certainly the beneficiaries of the network effect. That is, the network becomes more valuable as it gains more users.
Absolutely. Initially, would go to meetings and you could just almost immediately see people kind of turn off as soon as they recognize that you were there. Went from that to where you had time on the agenda to discuss that, and people were actually listening. So a slow process, but an effective one at the same time.
And you also mentioned slamming glass. I think maybe people outside of the profession may not appreciate that, like just how fast pathologists are with the old-fashioned glass slides, right? And it's comfortable, it's easy. They've been doing it for years and years and years. So to switch abruptly to a computer monitor could be quite a shock to their system. It also highlights that there's secondary benefits. So maybe making the primary read or the primary diagnosis might be much easier slamming glass or just moving that glass slide quickly across your microscope, but for the purposes of a cooperative group, or especially creating a biorepository where this is a living, breathing thing where you're going to be accumulating data, there's certainly going to be benefits to a digitized system. And ultimately, that's where we want to go. And the slamming glass might not be the best approach for that. It also highlights that many different use cases, not only making the diagnosis. So also, speaking of biorepositories, let's talk about the Cancer Genome Atlas. So tell us a little bit about that.
That was an interesting time. It was actually very exciting that we were essentially the first filter is how we kind of looked at it. So really any of the cases that would or was meant to be part of the Cancer Genome Atlas, really the first step after you received it and looked at it and said, yeah, it's a piece of tissue. And, obviously you're looking at certain things, really that macroscopic evaluation as it comes in the door. But after that, it really became an imaging project to where our group imaged all of the tissue that came in. We used the Viper system to share that data or share those images out with a ton of pathologists that were doing very detailed reviews, really much more detailed than what we had previously done. And a lot of that pushed the Viper system to where we had to make some enhancements, being able to, if you're looking at this type of cancer, then they were very specific. You need to collect this exact information. And it really was that first filter to whether that patient or that patient's tissue would become part of the Cancer Genome Atlas project. So a lot of stuff coming in, a lot of changes early on, really, really high volume. We expanded our imaging infrastructure, both hardware wise as far as scanners, a ton of data. So we had to make a lot of changes there. And then really some things that we had done a little bit of as far as data exchange. That really went to a whole new level with the cancer genome because all of the cases that passed needed to be pushed up to the data center that they were using, so that could be combined with molecular data and all the other bits of information that they were collecting for TCGA. So it was a very hectic time. We were onboarding a lot of new pathologists, excuse me, a lot of new pathologists just to do the work, to try to keep up. Creating a lot of very customized forms for that data collection, and then sharing that information back, and really having a ton of information and data that we needed to manage locally, and really coming up with new processes to do that work, as well as really the whole upload function. So, you think about if you're pushing one image, from point A to point B, and some of the bandwidth limitations that you're going to run across. I mean, that went up exponentially because we were sharing, hundreds or thousands of cases that, obviously the whole slide image was a large piece of that data, but there was, also various other pieces of information that had to get pushed up to the data center. So a lot of challenges really, but a very, very exciting time. It's really cool to see, all the things that came out of the work from the TCGA, um, still today, right? I mean, I just saw something 2 or 3 weeks ago where there was a new paper out that was based off of some of the data that they'd collected for TCGA. So really just to be a part of that was an exciting time, and to see the value that brought to the research community, it was very cool to be a part of that project.
It's going to be a huge opportunity for digital pathology. I think the purpose originally of the Cancer Genome Atlas was to look for molecular alterations in cancer, and then maybe to verify that we have the right tissue or what it corresponds to on the H&E. But I think there's going to be a huge opportunity, to mine the H&E images as the source of data and predictive and prognostic factors for patients. So is there a push towards that?
Certainly, we've had several discussions with various companies, and a lot of the people that we worked with 15 years ago, 20 years ago, they're now involved with, deep learning or AI, whether that's from a commercial perspective or, more of an academic perspective. And I don't believe I've had one conversation with anyone that hadn't already started evaluating or been evaluating or had already evaluated the data that was collected and shared as part of the TCGA. So I think, any of the AI companies that you're talking to, that was certainly some of the early work that they were looking at. Some of that data being publicly available, I think has been a huge push, for these AI companies, to get started and to really just move forward. So it even though that wasn't the intention, I think initially, like you said, there's certainly been a benefit there from a deep learning and AI perspective.
Yeah, I think the future is going to be very bright in terms of collecting data and mining data from histologic images. So, Tom, can you share anything about what you're currently working on now with us?
When I left NCH, it was tough because I think, we had a great team. We were able to accomplish a lot together, and but with all that being said, it was a good time to do something a little different. And in the back of my mind, even then, I was thinking it's probably not a good time to jump out of this digital pathology field, just because, like we've been talking about, just to see the progress that's been made, and really to see where things are at today compared to a decade ago, and where they'll be in the future. It was really a bittersweet thing to leave, what we had done. So we kind of knew all along that we wanted to do something different but similar. So we've created a new company, really with the idea that our initial push is to be able to generate data, manage data, share data. We've already started working with a couple clients. We still got some pieces that we're putting together, but we were able to bring some familiar faces from our experience over the years together to create HyperPath, and we're really excited to see where it can go. We feel like, the digital pathology world is just now taking off. We feel like we can bring an abundance of experience, and again, our initial push is generate, manage, share whole slide imaging data. Um, we've got a couple of robots. We have our infrastructure in place. We have an agreement now with a high performance computing and storage company that we've worked with in the past, so they can provide a lot of the services that we need. We're in the process now of evaluating other partners. We're really looking at some different analytics platforms. And our long term goal really is to provide services to biotech, pharma, CROs. And again, we've been very fortunate to bring on a couple clients already. So it's exciting to kind of get back into the game. I don't feel like I was really ever away. We planned on doing it all along. Things kind of fell into place. It's exciting. It's been a lot of time and effort to get this thing up and rolling. In the very near future, we hope to have conversations with a lot of the people that we worked with already, and we're already seeing that happen. So it's a pretty exciting time for us.
I think that is exciting. So before we wrap up, maybe just tell us, where you see things going in 10 years or so. We've come a long way in a relatively short period of time, but I think there's a bright future ahead. So what do you see in the next 10 years or so?
Well, you mentioned Moore's Law earlier, and that certainly has applied, and I think it's going to continue. We're going to continue to see some reduced costs. I mean, right now the barrier is really the cost to entry, I think, into digital pathology. As more competitors come in, that's going to get better. I really feel like the next 10 years are going to be mind blowing, to be honest with you, because I feel like a lot of these companies, some of these AI companies today are doing some really, really neat stuff, being able to see things that maybe we never didn't realize existed before. And that's really one of the nice things about the technology. As you collect that data is available. It's not a glass slide that goes into a drawer somewhere or maybe gets lost over time. This data is available, and these really smart data scientists are already doing some very neat things with the technology. And I think we're just at the beginning of it. I think 10 years from now, yeah, everybody in this country is going to have whole slide imaging capabilities. They'll be working with the same pathologists they're working with today, but those pathologists will have a whole new set of tools available to them. I think the molecular component of pathology is going to continue to grow. I see a lot of integration among, what we think or what I think about as digital pathology today, but really being able to get more of a true picture of what's happening with a patient and seeing, various types of imaging modalities, molecular data, even, clinical data in one place for a physician or a pathologist to make better decisions on how we're treating patients, and then really just being able to take all that data and make sense of it, because we're already creating a ton of data. I think the challenge now is it's almost too much data. It's hard to really for a person to really see that and evaluate it. And I think that's going to change over the next 10 years. And a lot of that's going to be due to deep learning and AI.
Let's make sense of all this data. Our guest has been Tom Barr. We'll see you next time on Digital Pathology Today.
This has been Digital Pathology Today. Please be sure to subscribe. Thanks for listening.